Thank you for that futuristic introduction. I'm honored to be here today to talk to you about perinatal mental health. My non-ACGME research fellowship over this past year has really only been made possible through the Utah STAR program, as well as through the support of our OBGYN department, specifically by our chair, Dr. Silver, in the OGRN in supporting the research capabilities. Dr. Emily Miller made an excellent grand rounds in the fall that I encourage you to watch if you have not already seen, that focuses more on the treatment of perinatal mood and anxiety disorders. A little bit of self-promotion. We're also going to do a pregnancy echo in June that focuses just on pharmacologic agents and how to choose between them. But today what I want to do is I want to spend the next 14 minutes really talking to you guys about what I've learned over the last year in building a framework for thinking about perinatal mental health, as well as starting to get you excited about it. I have no disclosures. Here are my objectives. But I really want to focus on three main goals, and that's to stay calm, euthymia, and that any decision that you make with the patient is the best decision at that time. So starting with staying calm. We know that perinatal depression occurs in about 10 to 15% of women, and perinatal anxiety in up to 20%. We once thought that pregnancy was a protective time period, but we now know this not to be true. This ends up being around 500,000 cases per year in the US, making it one of the most common, under-recognized complications of the perinatal period. The definition that I've liked the most over the last year is perinatal mood and anxiety disorders, which are mood and anxiety disorders during pregnancy or the postpartum period. And perinatal depression or perinatal anxiety is really one of the only psychiatric conditions that's defined by the time of symptom onset, which would be childbirth. The postpartum period that people consider as classified in this category is anywhere from 4 weeks postpartum up to a year postpartum. In my clinical practice, I consider up to a year postpartum to still be a perinatal mood and anxiety disorder. And that's a lot also because of how we've changed our thinking of making sure that we're continuing to take care of women during that year postpartum. So how good are we at screening and treating as OBGYNs, midwives, primary care providers taking care of pregnant and postpartum patients? And it really varies. We have about 50 to 98% of providers do screening for perinatal mood and anxiety disorders. And in surveys that have looked at OBGYN attitudes and beliefs, the majority of providers feel that treatment is important, that screening is our responsibility, but they don't feel confident in treating perinatal mood and anxiety disorders or really in their ability to screen or diagnose. One of those surveys had the statement, "I feel I've had the appropriate training to treat depression," and only around 30% of providers agree with this. Those that had better training were more likely to screen for perinatal mental health disorders. And this is where I want you to stay calm, that we really haven't been equipped with the capability to be able to do this. And that's going to be one of our goals, is to give you that training to allow you to feel confident in your ability to treat these women, because I know it's something that we're going to be able to do. So Austin Powers reference, this is Dr. Evil, and he's always talking about 1 million or $1 billion. Similarly, when we're thinking about barriers, there's about 1 million barriers to screening, diagnosis, and treatment of perinatal patients for mental health. But if we think back to the reason that we're all here to start with, which is taking care of patients, if we ask them what they want, they actually want to talk about mental health during the perinatal and postpartum period with their provider. So historically, I had mentioned that there was a pressure for this to be a positive experience that was protective from mental health disorders, but we know this isn't true anymore. And so women actually want trust, they want to avoid judgment, and they want to be able to talk about their mood with their provider in a way that's not going to make them concerned that they're going to be viewed as no longer fit to be a parent. So not only are they receptive to mental health advice during this time period, but they actually want to talk about it. So ACOG's formal recommendation for screening is to screen for depression and anxiety at least once during the perinatal period. And if this was before postpartum, then to also screen in the postpartum period. The American Academy of Pediatrics recommends screening at 1, 2, 4, and 6 months of their well child visit. What I do in my practice is screen at the new OB visit in the 3rd trimester and in the postpartum period. In terms of types of screening that you can use, it doesn't matter. As long as you screen, that's the most important aspect of it. The next thing I want you to take away from this talk is really to focus on euthymia with the patient. This is used a little bit more with bipolar patients, but I also talk to patients who have depression or anxiety about this as well. We know that pregnancy is a time period of expecting the unexpected, and I want to make sure that women have tools so that during these time periods that something occurs, that they're able to maintain a stable mood, whether that's through mindfulness, through coping mechanisms, or through medications, that those ups and downs of pregnancy, they're really able to maintain a stable mood. And when thinking about euthymia, let's think about when these disorders present. Dr. Wisner et al. In 2013 prospectively studied 10,000 women that they screened for depression with the Edinburgh Postnatal Depression Scale at 4 to 6 weeks postpartum. And about 15% of these women screened positive. They then had these women come in for a formal diagnostic interview, and they asked a few different questions. One of these was, when do symptoms start presenting? What is the time period of symptom onset? And they found that about 40% of women, this occurred in the postpartum period. And this is something I think that we know, that in the postpartum period, perinatal mood and anxiety disorders are more common than at other times. But it's also important to remember from this data that also means that 60% of women had symptom onsets before pregnancy or during pregnancy, which are also really great time periods to talk to women about their mental health, especially when they don't have that additional stressor of just having gone through a delivery and having a newborn at home. The other thing that they asked is, what are the diagnoses of women who screen positive for depression on the EPDS? And they found that the most common diagnoses was depression, which I think we could expect at 69%, but that around 20% of these women had a diagnosis of bipolar depression or bipolar disorder. The remainder of women had anxiety disorders, substance use disorders, other disorders, or no diagnosis. They also looked at comorbid diagnoses, and the majority of women had a comorbid diagnosis. About 2/3 of women with depression had it. And that was most commonly, over 80% of the time, the comorbid disorder was anxiety. So when we're seeing these patients in clinic, what do these patients look like? They present pretty similarly to outside of the pregnancy or postpartum period, similar to how a major depressive episode would present, with low interest, depressed mood, insomnia, fatigue, suicidal ideation. In the postpartum period, they can have a little bit more of irritability, agitation, anger, or hypervigilance. We know that anxiety is often prominent. They can have comorbid disorders, as in Dr. Wisner's study, of up to 66%. And then we also know that somatic symptoms of pregnancy and postpartum often overlap with mood disorders, which is important to think about. So back to thinking about euthymia, an important aspect of treatment is making the diagnosis. So I would encourage you to commit to a diagnosis. I put up a mnemonic that I had learned in medical school, but you could use whatever mnemonic you had learned in your training, of SIGI CAPS, which is sleep, interest, guilt, energy, concentration, appetite, psychomotor retardation or agitation or suicide, with having to have 5 of these symptoms, which the high 5 is to remember that you have 5 of these symptoms, with one of them being depression or loss of interest for over 2 weeks, to make a formal diagnosis of depression. And remember Dr. Wisner's study, where about 20% of women had bipolar disorder who were screening high on the Edinburgh Post-Natal Depression Scale. It's important in these women to rule out bipolar, psychosis, and suicidal ideations to really make sure that you feel like they're safe, and to start thinking about any comorbid conditions that they might be presenting with, like anxiety. The idea of euthymia is also important when we're talking about women who already have a diagnosis of depression and are on an antidepressant medication. Dr. Cohen et al. In 2006, who's really one of the pioneers of perinatal mental health, he's the head of the program at MGH in Boston. Him and his group looked at women who already have a diagnosis of depression who are on an antidepressant medication. They compared women who continued their medication to women who discontinued their medication and looked at the rate of relapse of the depression. And what they found is that women who maintained their medication were at lower risk of relapse than women who discontinued their medication. So if you look at those red boxes, women who continued their medications had a rate of relapse during pregnancy of depression at about 25%, compared to women who discontinued their medications had a higher rate of relapse during pregnancy at about 67%. This is an important aspect of thinking about the risk factors for perinatal mood and anxiety disorders, where a history of mental health disorder is really one of the leading risk factors. Of course, there's others as well that make you want to start thinking about the disorder. Remember that the majority of women improve who have perinatal mood or anxiety disorders. When they look at women 4 months to 3 years postpartum, about 30% of women still meet criteria for depression. And you could make a lot of hypotheses about why this occurs. But one of the aspects is to make sure that we continue to take care of these women in that postpartum period. And then also to make sure that we're actually treating to remission. So we're treating to an improvement in their depressive or anxiety symptoms, as well as the length of treatment. Outside of pregnancy, it's recommended that you maintain euthymia on medications, if that's the treatment option that you've chosen, for 6 to 12 months to decrease that risk of recurrence. The last thing I want you to take away from this presentation is that any decision that you make with the patient is really that best decision that you can make at the time. After you diagnose the patient, talk to them about the diagnosis, talk to them about the treatment options. It can be pretty stressful. It's really a risk discussion of those treatment options. And so reminding them that the decision that they make is really the best decision that they can make at the time. These are some of the risks that I talk about when I'm having a risk discussion of untreated illness compared to pharmacologic treatment. Non-pharmacologic treatment is the third option that I talk about. It's just not on this slide. But I think that after you have this risk discussion, it's interesting because you can have two patients who are in the same scenario at the same gestational age or postpartum period, and they can make a completely different decision of what they want to do with their treatment. And I think that this is a really important aspect because it's a good reminder that we're doing a good job with our counseling and we're really empowering women to make the decision at the time that they feel is best, and we're respecting their autonomy and values in this. ACOG and the American Psychiatric Association also talk about, when you're having this discussion, talking about the severity of their illness at the time when discussing treatment options. If you do choose to do pharmacologic treatment, asking what has worked before. If you use a medication that you already know has worked with the patient, it'll decrease the exposure to the untreated illness, as well as increase your chance of success, but decrease that exposure to the illness, and decrease the amount of time that they have an untreated illness. And then also thinking about what their main symptom is, and really thinking about what your diagnosis is. Continuing to address with women, either who have chosen to start medications or non-pharmacologic agents, or who have chosen not to do anything, can be really important because we know that things change in pregnancy, and so women may change their mind. So readdressing it with them later on to see if they've changed their mind on any of the options that you had previously discussed. And then making sure that you're treating to remission until their symptoms are no longer there. There's 3 areas that I think we can improve on. One is in our conservative recommendations, talking about lifestyle, prioritizing sleep for mood, getting outside, walking around the block once per day, and then healthy eating and the decisions that you're making. I think we can improve in our ability to use medications to treat women to remission, to treat them for that full time period to decrease the risk of recurrence, and in committing to a diagnosis, which will help us to think about the symptoms that they're presenting with and in choosing a medication. And then also in our models of care, I think we can build tools to increase our primary OBGYN's ability to treat patients and then use higher level referrals for patients who don't improve or for patients who have bipolar disorder or need a higher level of care. These are the resources that I've found very helpful over this last year. I see our role as screening, diagnosing, treating perinatal mood and anxiety disorders, and destigmatizing and advocating for the mental health of our patients. Remember to stay calm, the goal of euthymia, and remind the patient that any decision that you guys are making is the best one at that time. These are my references. And I'm excited to take questions.